شكرا دكتور بهاء. الحقيقه انا هكلمكم النهارده على what was mentioned by Professor يحيى الطراف اللي هو computed tomography assessment of close reduction in DDH. طبعا I acknowledge the help of my colleagues in our department. I have no disclosures and informed consents were taken from all parents. Radiological assessment after close reduction in DDH involves plain radiography. وزي ما الدكتور يحيى تفضل وقال plain radiography never tells you where the ossific nucleus is exactly. It can tell you on the AP that it's there, but it might be posterior because it is not a three-dimensional image, and you cannot get a proper lateral view in those patients with hip spikers in the human position. Arthrography is another technique where you do on table, which I'm not familiar with and I've not used. And computed tomography is something you would do post-reduction after application of the hip spiker, and you would see then where the ossific nucleus is lying exactly. The aim of this study, which was done in our department, was to assess the role of computed tomography in evaluation of close reduction of DDH in infants and children immobilized in spiker casts. We had 16 infants and children with 20 involved hips with an age range of 12 to 24 months. Well, the mean was 19.6 months, 12 were unilateral, 4 bilateral, and 1 had an ipsilateral talipes equinovars. They were all treated at Al-Hadra Orthopedic University Hospital, Alexandria, during the period from January 2014 to 2016 in the month of February. All children and infants were involved or were exposed to the same sort of full history taking, clinical examination, pre-reduction plain radiological assessment, and under GA, percutaneous adductor tenotomy and close reduction and application of hip spiker cast was done in the human position, where the hips were flexed 90 or 100 degrees with 45 or 50 degrees of abduction. And we actually did measure the safe zone of Ramsey on table, and it was more than 30 degrees. So you would reduce it at 50 degrees of abduction, and you would go to 20 until it dislocates, or maybe more in some patients. At least it was 30 or more. Post-reduction multi-slice CT was done with emphasis on the coronal and axial images to assess adequacy of reduction, and intra-observer variability was looked at, where one fellow expert radiologist who was a senior member of the radiological department assessed adequacy of reduction based on CT on 3 separate occasions with blinding. يعني بص على الاشعاعات مره ومره ثانيه ومره ثالثه من غير ما يبقى عارف هو قال ايه على السي تيز دي قبل كده. We looked at 3 variables on the CT scan: the modified Shenton's line, which is very similar to what you see on a plain AP view, where a line was drawn along the inferior aspect of the femoral neck, together with the cortical margin inferior to the acetabulum. And this is an intact modified Shenton's line, and on the other side you can see very well that it's interrupted. And the interrupted modified Shenton's line was considered a positive finding. We also looked at what's called the posterior neckline, which was described by Cooper et al. In 2014, and this involved drawing of the outline of the acetabulum and drawing of the outline of the cortical margin posterior to the acetabulum, and this point between these 2 lines was considered a reference point. And then a line was drawn along the posterior aspect of the neck, so that with this line lying posterior to that reference point, this was considered to be a posterior displaced posterior neckline, and this was considered a positive finding. Normally you would find this line on this side anterior to that reference point. as you can see here. So this is a posterior displaced neckline on the right, and on the left it's an intact posterior neckline with the posterior neckline anterior to the reference point. Femoral head coverage was also looked at, and this was a modification of what Morin described on ultrasound in 1985, where 3 lines were drawn. A line was drawn along the outer aspect of the acetabulum, parallel to the iliac bone. Another line was drawn along the cartilaginous, medial side of the cartilaginous femoral head, and this was outlined by the pulvinar. And then a third line was drawn along the lateral aspect of the femoral epiphysis. So you've got 3 parallel lines here. The distance between A and B was considered D small, and between B and C was considered D capital, and the ratio between D small and D capital times 100 was the percentage of the femoral head coverage, and anything above 60 was considered a successful reduction, and less than 60 is a positive finding, indicating that the femoral head was not well covered. We also looked at presence or absence of the femoral head ossific nucleus and its size and the shape of the pulvinar. And then we looked at, statistically, at methods of assessment. Sensitivity, which measures the proportion of positives that are correctly identified. Specificity measures the proportion of negatives that are correctly identified. And accuracy measures the proportion of the true results, both true positive and true negative, among the total number of cases. Intra-observer variability is the amount of variation one observer experiences when observing the same material more than once, and reliability is the ability to reproduce the same results again and again as required. This is essential as it builds trust in the methods used and the statistical analysis of the results obtained. According to CT criteria, closed reduction was successful in 16 hips. Sensitivity, which are the positives correctly identified, and this was highest with the femoral head coverage. Specificity, negatives correctly identified, was highest with the posterior neckline, followed by the modified Shenton line. And accuracy, true positives and true negatives, highest with the posterior neckline. The cartilaginous femoral head was seen in all hips, where the femoral ossific nucleus was present in 16 and absent in 4, and the pulvinar was normal in 10 and hypertrophied in 10. Intra-observer variability, the 3 observations of CT variables by one observer yielded identical results with blinding of previous assessments. And the best level of reliability was seen with the posterior neckline at 82.3%. I'll show some of the cases we've been doing. The classical sort of presentation, a 24-year-old, month-old, female, Trendelenburg gait, limited abduction, right lower limb shortening, and plain radiographs showed right DDH. Treated by closed reduction and abducted tenotomy. And this is the post-reduction X-rays, where you cannot tell exactly where the femoral ossific nucleus is lying. And on CT scan, you can see that your modified Shenton's line is not interrupted, is intact. The femoral head coverage was 0%, and the posterior neckline was intact. So we decided to carry on closed reduction. This patient had undergone a successful closed reduction, and these are his X-rays 12 months later, with an intact Shenton line here, of course a dysplastic acetabulum, which you're going to be waiting for remodeling to happen, and that involves anterolateral deficiency, which you hope will improve and remodel as time goes by. Another patient, 20-month old with the classical presentation of DDH, the left side involved, closed reduction and adductor tenotomy, and post-reduction, you can't really tell again where the ossific nucleus is lying, although it appears to be subluxed a little bit. CT scan, posterior displaced posterior neckline, and don't get fooled by seeing the plain radiographs where you see that there is maximum abduction. It's not. This is the amount of abduction you see. الابدكشن اللي انت شفته هنا شايف قد ايه؟ زي ما تكون frog lateral. This is not frog lateral because this has been commented upon by some senior colleagues before in meetings. This is the amount of abduction you have. Okay? فدي posterior displaced neckline. Femoral head coverage was 34%, and there was an intact modified Shenton's line. This patient had a failed closed reduction and underwent open reduction. In conclusion, CT is an accurate modality for assessing adequacy of reduction of DDH through spica casts even if the ossific nucleus is not visible. Femoral head coverage gave the highest sensitivity. However, posterior neckline gave the best specificity and accuracy. The best level of reliability for adequacy of reduction was seen with the posterior neckline at 82%, followed by the modified Shenton's line, and lastly the femoral head coverage. Consequently, we suggest that the posterior neckline should be considered as the preferred method for assessment of hip relocation. Thank you very much. طبعا هو posterior neckline is almost the other side of the anterior